So we already have a diagnosis that this patient has got papillary thyroid carcinoma. So the next step is going to be, the first step going to be surgery. We have to prepare the patient for surgery. Now, when you have a case of malignancy, it is not that one particular doctor, surgeon deals with it. What I mean to say, it's not ENT alone. We would like to get contribution from other departments or help from other departments. So in short, it's going to be multidisciplinary approach. More than 2-3 departments, we are going to sit together, we are going to discuss about it, and so that we can get the best outcome for the patient. So the other departments, which includes oncosurgeon, radiation oncologist, and endocrinologist, and nuclear medicine. Why all these departments will be involved, I will tell you step by step as and when we come to the topic. So, it has been decided the whole thyroid has to be removed. Or suppose if the patient has come from some other hospital and they want the rest of the thyroid to be removed, which I have already discussed in the part 1, is going to be completion thyroidectomy. So either it is near total thyroidectomy or completion thyroidectomy. The first thing is we get a consent from you. In that consent paper, you have a diagnosis, you have the surgery, which I have already told you, near total thyroidectomy or completion thyroidectomy, and there will be complications written on it. I will tell you about the complications also. So the patient has to go through that, write their name and sign it along with the date. The same thing will be done by your bystander, the one who has come with you as a witness, and the doctor. And I would like to tell you one more thing. The consent is for surgery, and suppose there is one particular complication for this thyroidectomy, especially this type of conditions. If suppose post-operatively the patient has got breathing difficulty, we have to make a small hole here to help him to breathe, which is called as tracheostomy. We take a consent for tracheostomy also. If necessary, we can do that. Now, when all this consent paper, everything is going on, the investigations could be ready by this time. With all this necessary investigation, we have to first meet a physician. And if necessary, he may ask you to get a clearance from pulmonologist or radiologist as per your condition. And with this, all these reports, when everything is fine and you are okay, when they feel that you are fine to go to the operation theatre to get operated, all the papers will be sent to the anesthetist. He will examine you and give fitness for clearance for surgery, and you will get a date. Suppose tomorrow is the day for surgery. Tonight, dinner, you can have dinner. Night, 12 o'clock onwards, you are nil parole. Now to drink anything till further orders. Now, before going for surgery, we would like to have a look of the vocal cords. So, one of the junior doctors or one of the doctors will pass in a flexible endoscopy through the nose, down the throat, to see the vocal cords, whether it is moving normally or not. I'll tell you the reason now itself. Because the thyroid is so situated that we have two important nerves on either side of the thyroid, and it goes inside the voice box, and it has got two important functions too. One is normal phonation, which is talking, speech, and for normal breathing. So if by chance this malignancy has affected the thyroid, affected the nerves, or by chance when we are operating, we come to know the malignancy has engulfed the nerves, or when we operate, because of the heat of the equipment, sometimes the nerve may get damaged. If it is so happen that this nerves on both sides get affected, the main two functions which I have told you, it will be affected. So that there will be loss of voice, there will be hoarse voice, and there will be breathing difficulty. So pre-operatively, we would like to know whether the vocal cords are normal or not. That's why we are doing a flexible endoscopy. So this I have already mentioned. Now coming to the complications. So the first one being bleeding, which can be intraoperative during surgery, or it can be immediately post-operative, or within few couple of days, which can be managed. And I'll tell you how we'll prevent that also. The second one being like how I mentioned before, there can be a change of voice. It can be temporary or permanent depending upon the nerve damage, whether it is one side or both sides. Or there can be breathing difficulty, which again can be temporary or permanent depending upon whether the nerve has been activated on one side or both sides. The last one, fourth one, which I have mentioned, is the level of calcium in your body, which is termed as hypocalcemia. This can occur post-operatively. Why does it occur? Because the calcium in the body, it is regulated by gland called regulated by parathyroid hormone, which is secreted by a small gland situated just behind the thyroid. Usually when we do thyroidectomy, we preserve this gland, or if it so happens it comes out very implanted. If by chance, or if by this hormone is getting, this gland is getting affected by surgery, it may not work. Maybe it is temporary or maybe it is permanent. In that case, the calcium level in the body may come down, which is not good, which can turn to be dangerous. So what are the problems with hypocalcemia? I'll tell you later on. So that at the same time I can tell you the treatment for that. That's all. And once the thyroid gland is removed, for the rest of your life, you have to replace thyroid hormones. You have to take L-thyroxine, Thyronome, whichever your doctor is prescribing, lifelong, along with calcium, vitamin D, and cholecalciferol, maybe cholecalciferol also. So, and there's one or two more complications. You have a big stitch here. This can get infected. Some of the doctors, they do endoscopically, so you have only two small openings. And this stitch can get infected, or there will be a collection of fluid which is called seroma just below the nose, which also can be treated. So these are the usual complications. So about nasal endoscopy, which I have already mentioned, and why we are doing it also I have mentioned. So before surgery, at least 4 to 6 hours the patient has to be nil parvoid. So we know what is the surgery. I have written only thyroidectomy. It is going to be near total thyroidectomy or completion thyroidectomy if the patient has already undergone surgery from some other hospital. So the surgery, it takes about 2 to 2.5 hours. The whole time spent by the patient inside the operation theatre. Once the patient comes back to the post-op ICU or surgical ICU, the position of the patient is going to be like this. The head end will be propped up 30 degrees and they will have a big bandage around the neck or an oxygen mask also. They will be breathing normally. There will be IV fluid which will be going on, and the staff nurse there will monitor you. They will be monitoring blood pressure, pulse rate, respiratory rate, temperature, any complaints or any swelling in the neck, any breathing difficulty, and so on. Since you have pain and discomfort in the neck, painkiller will be going on along with antibiotics. These are the usual things. Now, if you see this diagram, photograph, you have a stitch and you have a drain, if you can see. This drain is a vacuum drain, so that if there is any bleeding inside, it can suck out the blood and it gets collected in a bag. So I'll show you a video how it works. This is a suction and this is a bag where it will get accumulated. So this is going to stay for 2 to 3 days. So usually the next day is going to be, the collection is going to be 100 ml, and subsequent day it is going to be less than that, say about 50 to 75 ml, and usually on the third day when it is less than 25 ml, we would like to remove it and we will give a smaller pressure bandage. That's how it's going to be. And third day the patient is ready. Usually the third day the patient is ready for discharge. All the complications I have already mentioned in detail except for hypocalcemia, which I will tell you later. Now the discharge advice, the time for discharge. Discharge time, you get few medications. You have to take a course of antibiotic, usually 5 to 7 days after food, and painkiller usually for 3 days, and after that, if necessary, you can take one. And the wound dressing has to be done every 2 days, and the review is going to be after 7 days. And after 7 days, when you come to us, we examine the wound, everything is fine, we remove sutures, and the biopsy report will be ready by then. And sure, since the topic is of papillary thyroid carcinoma, it is going to be the same. Now, take home message, what are the things you are supposed to do and what you are not supposed to do at home. This is what I am going to tell you next. So, when we give this antibiotic and painkiller, we will give you calcium tablets also. During the stay in the hospital, post-operatively, immediately post-operatively, and few hours after post-operatively, and the same day night and the subsequent morning, we will check your calcium level. Corrected calcium or ionized calcium. And we will see how much tablet, how much grams of tablet you need, calcium correction you need. So usually the patient will be discharged with 1 tablet 3 times daily, or maximum is going to 2 tablets 3 times daily. So vitamin D comes along with that. It's a combination of calcium and vitamin D. So that also will be getting it. Now, this biopsy also I have mentioned. Now the take home message, what are things to be done and what are things which should not be done. So this is a major surgery. So that doesn't mean that after being discharged, you are at home, confined to bed, or sitting in a chair, continuously taking rest. No. You have to be ambulant. The more ambulant you are, the better for you. You should be in a balanced diet. Better to avoid oily foods. You should be on a balanced diet, and you will be given vitamin supplements too. During this waiting period, when the doctor has called you back, you can turn your head to the right and the left down, but try to not to overextend your neck upwards, because there is a stitch which has already been removed within 7 days. And one most important point which I want to tell you is, during discharge, the doctor must have told you, if you have already been taking L-throxine tablet, please discontinue that at least for 4 to 6 weeks. Because the treatment is not complete here. With surgery, it doesn't stop with surgery. Usually, this thyroidectomy, whatever the form is, near-total thyroidectomy, total thyroidectomy, completion thyroidectomy, it is done in a town or city. But the further treatment, it has to be done in the highest level possible. That is, in a regional cancer center or any private hospital which has got a facility of nuclear medicine. That's what I initially had mentioned. Why? We have to see next if any thyroid tissue has been left behind, which we can find out by atom scintigraphy. So to do that test, for the best outcome of the test, you have to avoid any iodine containing products. So first thing is, you have to stop L-throxine. Discontinue L-throxine if you have been taking L-throxine. Now, another few advice is, the patient will complain of throat pain, but mind, we have done operation outside in the neck and nothing inside. But why this throat pain? Because the anesthetist has put in a tube to pass on the anesthesia gas, and this can irritate you for 2 to 3 days. And in some of the patients, they can complain of pain here, nape of the neck. That is because the patient has been laid up straight during the surgery with extended shoulder bag in the back position. So this abnormal position, which is there for almost 2 hours, so this pain can trouble you 2 to 3 days after surgery. So what you do? Some local massage and just nape the neck, and you can apply local heat also, augmentation. That can help you out. So there will be a slight change of voice, and that can recover. If it's temporary, it will recover. If it is more, you have to inform the doctor. Usually, you will not have breathing difficulty. Now, when the L-throxine tablet had been stopped, what are the changes? See, a normal person, we need iodine. This particular patient who has been taking L-throxine, getting iodine supplement, it has been stopped. So what will happen? The iodine get depleted from the body, whatever is there, it gets depleted. So there will be body changes. they'll put on weight in spite of having, they will put on weight and their appetite is also going to be low. They'll have fetal edema, their round face. This will develop slowly, one by one. Coarse skin, thick skin, hair fall, change of hair color, and most important, they'll get irritable for small things. There'll be wide mood swing. Maybe it was not their character, but because of low level of thyroid hormone in the body, they may go into depression also. These are the usual things. And in females, when they have period, it may get prolonged. So these things are really going to trouble the patient. So husband or son or whoever is there along the patient, we have to be very patient along with the patient. We have to tell them these are the side effects because of the withdrawal of the drug from the body. So please bear with it for a few days till the treatment is over. Now the electrotoxin has been stopped, and not only that, the patient is not supposed to take anything which contains iodine. The few things which contains iodine I have displayed here. You have to avoid all that. Steroids, cough syrup, any treatment, any antihistamines, then vitamins, thiazide diuretics, milk products, then any sea products, fish or sea products, then any iodine containing cough syrups. Then the very common one is the salt. Usually in most of our house we use iodized salt. So they are supposed to avoid iodized salt and use normal salt without iodine. This will go on for a period of 4 to 6 weeks, because the iodine level has to be completely removed from the body. So these are the precautions. You're being prepared for the next iodine skin degrafting. Now, before ending this topic, let me tell you about hypercalcemia. This the doctor will warn you before discharge. He will tell you, please call me immediately if you have fever, any pricking sensation in ear which is painful, any breathing difficulty. Along with that, he will tell you the signs of which is complaints related to hypercalcemia also. These are the patient, there will be tingling sensation around the mouth. Then they will say numbness in the hands. Then it will slowly increase to muscle pain and cramps. Patient will have a mood change. Then they will have breathing difficulty. And along with that, there will be tremors. Even at this point, if it is not been diagnosed and the patient has not got proper treatment, replacement of calcium, it can precipitate cardiac problems also. So when the patient comes to us with hypocalcemia, we usually treat them in the ICU sometimes because we are afraid that they should not get this cardiac issues. That's why. So when the patient comes to us, the first thing we are going to do is clinically see whether they have any signs of hypocalcemia. That is, we have a BP cuff and the inflation will be 20 millimeters above the normal, millimeters of mercury above normal. What will happen is the patient, the particular hand where he has a BP cuff, it will go into cramp, it will go into a spasm. And if you just touch the part here, the whole one side of the face will go. That means clinically the patient has got hypothyroidism. Now, as soon as the patient arrives in the emergency room, we'll draw blood to check serum calcium. Along with that, the level of parathyroid hormone, vitamin D, phosphorus and magnesium. As soon as blood is drawn, we'll start treatment. We'll give calcium gluconate over a period of 3 hours. And after the 3 hours, we'll draw blood again and check calcium alone, not the whole thing. And to find out whether the calcium has become normal or not. Once the calcium has become normal, you will be advised to increase the dose of calcium depending on the previous dose. Along with that, vitamin D and sometimes cholecalciferol will be added to it. This is how we manage hypercalcemia, and maximum you need to stay for a day, and next day morning you will be discharged. And you will be advised to do serum calcium checkup. The doctor will tell you how often to be taken. That is how it is done. So the next video, the fourth part, is going to be about iodine scintigraphy and radio iodine ablation. Please do watch that. Thank you so much.